So, today my topic of discussion is oxygen administration. Oxygen is a colorless, odorless, tasteless gas that is essential for the body to function properly and to survive. Oxygen therapy is the administration of oxygen at a concentration of pressure greater than that found in the environmental atmosphere. The air that we breathe contains approximately 21% of oxygen. Oxygen therapy is a key treatment in respiratory care. Indications for oxygen administration are acute respiratory failure, acute myocardial infarction, cardiac failure, shock, hypermetabolic state induced by trauma, burns, or sepsis, anemia, cyanide poisoning during CPR. Oxygen is used during anesthesia for surgery. Then comes contraindications. Administer with caution to the patient with COPD, atelectasis, that is collapse of lungs, and oxygen toxicity. Then sources of oxygen in hospital. The therapeutic oxygen is available from two sources, that is wall outlets and oxygen cylinders. Oxygen cylinders may be stationary or portable. Here we have the pictures of oxygen cylinder and wall outlet oxygen. Then oxygen delivery system. Number 1 is nasal cannula, simple mask, partial rebreather mask, non-rebreather mask, Venturi mask, oxygen hood, oxygen tent, ambu bag, tracheostomy collar, and T-pipe. Then nasal cannula. A nasal cannula is a simple comfortable device. The two cannula are about 1.5 cm or we can say half inch long, protrude from the center of the disposable tube and are inserted into the nose. Low flow up to 5 liters of oxygen can provide through nasal cannula. Here you can go through from this picture. Then simple mask. The simple mask delivers about 35 to 60% of oxygen with the flow rate of 6 to 10 liters per minute. Then comes partial rebreather mask, which delivers about 80% of oxygen with the flow rate of 6 liters per minute. Then non-rebreather mask, which provides highest concentration of oxygen about 95 to 100% with the flow rate of 6 to 15 liters per minute. Then Venturi mask. I hope you all are well known about it. Then oxygen hood. Oxygen hood. Basically, an oxygen hood is a clear plastic compartment that resembles a hood that fits around the neonate's head and provides warm and humidified oxygen to the infant. This allows the neonate to receive a desired FiO2 in order to maintain the appropriate oxygen saturation. The oxygen hood only surrounds the head and neck of the infant and leaves the remainder of the body available for care. Then comes oxygen tent. An oxygen tent is a bendable piece of clear plastic held over child's bed or crib by a frame. The plastic is then tucked under the mattress. Child can move around on his bed without having to wear an oxygen mask. Humidity helps prevent the loss of water from child's body as he breathes. Then there are some journal instructions which we have to keep in mind while performing the procedure of oxygen administration. So first of all, oxygen should be treated as a drug. The 5 rights of medication administration is also pertain to oxygen. When using an oxygen cylinder or central supply, use a regulator and humidifier. Every part of the apparatus should be clean to prevent infection. Change nasal catheter at least every 8 hours or more often to prevent blockage of the nasal catheter by mucus plug. When oxygen therapy is to be discontinued, it should be done gradually. Then articles or equipments, client's chart, or we can say prescription chart, oxygen connecting tube, flow meter, humidifier filled with sterile water, oxygen source, that is wall outlets or oxygen cylinder, tray with nasal cannula of appropriate size or mask, kidney tray to collect the waste, adhesive tape, scissors, oxygen stand, gauze pieces or cotton swabs to clean the mask and the nasal cannula. No smoking board is mandatory to prevent the fire. Then gloves to maintain the sterility or to prevent the infection. Then pre-procedural steps. Identify the patient, introduce yourself to the patient and child, explain the procedure to parent and child, check the patient's identification data and diagnosis, check the dose, device and flow rate of oxygen, prescription date and signature of physician on the treatment chart. Keep the patient in propped up position in older children. Place no smoking sign in appropriate size. Then comes intra-procedural steps. First of all, wash hands. Put the source of oxygen on to check whether it is working and check the bubbling in the humidifier. Put the patient in a comfortable position, preferably semi-Fowler's or Fowler's position. Clean the mask or prong with saline swab starting with inside and proceeding to outside. Connect oxygen mask or prong to the oxygen source with humidifier. If using partial rebreather or non-rebreather mask, allow the reservoir bag to fill completely. If using Venturi mask, the adapter device should be selected and applied to deliver the oxygen concentration that is ordered. In case of nasal cannula, place gently the prongs into the patient's nostril, draping the tubing over the patient's ear and sliding the fit connector up under the chin to hold the tubing securely in place. Dip the tip of tubing in the water to check for bubbling. Apply the mask by placing the molded plastic mask onto the face, over the nose and mouth. Pull the elastic strap over the patient's head to the back of the head in front of chin and adjust the strap on both sides of the mask. The mask should fit snugly against the face but must not press so tightly as to leave impression on the skin. Check the vital signs in between. Then, in case of oxygen hood, wash hands. Put the source of oxygen on to check whether it is working and check the bubbling in the humidifier. Provide comfortable position to the patient. Clean the hood with saline starting from inside and proceeding to outside. Connect the tubing to the oxygen source. Check the flow rate. While placing hood over the head of the infant, must make sure the edges of the hood do not rub against the chin, neck and shoulder. Oxygen should not be allowed to blow directly into the child's face as it can cause injury. Check vital signs and saturation in between. Then post-procedural steps. Stay with the patient till the patient is comfortable. Keep patient warm. Clean and replace the articles in the utility room. Wash hands. Evaluate the patient's progress. Assess the nostrils of patient every 8 hours for dryness and irritation in case of nasal cannula. Record the time, flow rate and patient's comfort with oxygen use. Check the deteriorating symptoms after removal of oxygen inhalation. Monitor the effect of therapy with pulse oximetry and blood gas analysis. Assess the patient for tolerance and appropriateness of therapy. Do proper documentation. To discontinue the oxygen inhalation, close the main valve first, then loosen the catheter slowly. Stop oxygen carefully. So it was all about my topic. At last, thank you.